I'll introduce you first.
Okay.
Hi, everyone. Welcome to our multi-heart lecture series. We had an amazing meeting that was led by Dr. Jordi and Dr. Latif, and that I enjoyed very much. And now we have an amazing lecture as well by Dr. Raul Santos. Dr. Santos is an associate professor and director of the Lipid Clinic Heart Institute University in Sao Paulo, Brazil. He's a researcher at the Hospital Israelita Albert Einstein, as well as past president of the International Atherosclerosis Society. He has over 500 publications, including top journals such as New England Journal of Medicine, multiple of those, JAMA Cardiology, European Heart Journal, and every top journal in cardiology. He'll be talking today about his main topic, that is the risk heterogeneity and targeted therapies for familial hypercholesterolemia, an example of precision medicine. Thank you so much for joining us. I'm very excited about your lecture.
Thank you, Leandro. It's a real privilege to join you guys on this, and I'm really honored. So you already did the introduction of my talk. So this is my conflict of interest with some pharmaceutical companies that do actually medications for people with FH. So quickly, my idea is really talking with you about what is FH, discuss a little bit about the new epidemiology and natural history of the disease, because we have to remember that despite the fact that disease is not so much diagnosed, a lot of people with high cholesterol are taking statins, and this may change the natural history, even if they don't know they have FH, right? I'll discuss a little bit about the heterogeneity in cardiovascular risk. Definitely people with FH have higher risk of having MIs, strokes, or dying than the usual population. But as I'm going to show you, this risk is very heterogeneous and depends on many aspects. I'll discuss about customization of therapy, because unfortunately, the newer drugs like PCSK9 inhibitors are not available for everyone. The costs are still high. And the question is, do everyone with FH deserve to be treated with a PCSK9 inhibitor? And I'll talk to you a little bit about the newer therapies that we're having for the disease overall. So basically, if I had to, let's say, summarize FH in a nutshell, I'd say there's usually a disease with people with very high LDLs, usually over 190, 106 milligrams in kids. It affects probably 1 in 300 people, but the prevalence is a little bit variable. In the families, it's very important when 1 in every 2 people are affected by the disease and autosomal dominant disease. Fortunately, the homozygous FH phenotype is rare, because this is a really bad disease, as I'm going to show you, probably 1 in 300,000 to 1 in a million. And as I said before, FH is associated with 3.2-fold greater risk of cardiovascular disease, especially coronary heart disease, in comparison with the general population. And unfortunately, this happens very early in many people. We might find the cutaneous stigmata, so there's xanthomas, antelasmas, but it's not frequent nowadays. And definitely, we must think of FH when we're finding someone with early coronary heart disease, or someone who has early cardiovascular disease in the family, dyslipidemia in the family. And definitely, when we find an index case, we must check the family. And it's true, it's hard to normalize LDL, because usually LDLs start very high in people with FH. So this is very elegant data from Amit Kher and colleagues, really showing that, okay, FH is associated with a greater risk of events, definitely, and actually much greater than people with hypercholesterolemia of other causes. So you can see here people who have the monogenic defects, and it's not frequent, right? I think in the past, we used to think, oh, everyone with very high LDL have FH, and this is not true. Actually, they found the mutations that cause FH in only 2% of these people with LDLs over than 190. But importantly, when we see the rates of coronary heart disease in people with LDLs over 90 and over 220 milligrams per deciliter, you see that actually people with FH have a 3-fold greater risk of developing disease, even in comparison with people with very high cholesterol levels of other causes. So, okay, this is a severe disease, and definitely FH is worse than the usual hypercholesterolemia, because you're born with FH. So your cholesterol is high since very early. And talking a little bit about the epidemiology, in the past we thought that it would affect probably 1 in 500, but nowadays it's much more frequent. We have 2 meta-analyses published almost concomitantly in JACC and Circulation showing exactly the same thing. The prevalence of the disease, of the phenotype at least, is 1 in 311. But as you can see here, when we look for FH in people who have coronary heart disease or stroke or other causes of other manifestations of atherosclerosis, you see that it's much more frequent. So probably 1 in 17, 1 in 15 people who develop coronary heart disease will have FH. So this is frequent, right? And definitely when we find someone where we suspect that might have FH, we should check the family, we do the cascade screening. So, okay, so this is the past, right? So this is what happened before we started having effective therapies for lowering cholesterol. Before the age of statins, 1969, I had 6 years at this time. So you see here, by the age of 40, 1 in every 4 men would already have coronary heart disease. By the age of 50, 1 in 2, 12% of women. By the age of 60, 70% of men and 60% of women. So basically, this is what was the kind of epidemiology that we had in the 60s and in the 70s about this disease. Certainly a small number of patients because diagnosis was much worse at that time, and maybe a little bit over exaggeration on the risk. But this is what we had in the past. So very bad disease, early disease, and almost everybody, at least 50 to 70% of people who had the disease will get coronary heart disease sometime. Okay, what's the contemporary epidemiology of FH? This is the FH-SC Studies Collaboration meta-analysis. So more than 60,000 people from 56 countries in the world. You see the mean age is around 46. And you see that actually 20% of men and 12% of women with FH will have coronary artery disease. So 1 in 5 for men, 1 in 10 for women. And as you see, 15% of men and 7% of women will have premature coronary heart disease. So these numbers are much lower than the numbers that I showed you from the 60s, probably because this is a much greater population, much more well characterized, and certainly because of therapies. So as you see also, actually higher the LDL cholesterol, the greater the risk of events. But when they say, look, 20% of coronary heart disease in people with 46 years old is a lot. I fully agree with that. Well, okay, so, and actually the natural history of FH has changed because of statins. Okay, statins reduced LDL between 30 and 50%, and this is what happens also for people with FH. They're not perfect because a lot of people still persist with high LDLs in FH despite statin therapy, but statins can make a lot of difference. We don't have randomized clinical trials in FH because it's totally unethical not to treat very high LDL cholesterol levels. But you can see here in observational studies that actually we can reduce the risk of MI to similar levels to the ones of the population that doesn't have this disease. And actually, if we start treating children very early, by the age of 13, we will reduce the risk of events. And this observational data from the Netherlands is quite interesting because, let's say, a not robust reduction in LDL, only 30%. And these kids were followed for 20 years. They became adults. And actually, just 1% of them developed coronary heart disease in comparison with 26% of the parents who didn't have an opportunity to be treated at that time. So clearly showing here that we can really change natural history of coronary heart disease for people with FH. So, but basically, that's why we need to make diagnosis, and that's why we need to treat. But as said, actually, okay, the disease is associated with a greater risk of atherosclerosis, but the risk is heterogeneous, depends on different aspects. And when I'm talking about this kind of heterogeneity, I'm really talking about, let's say, customization of therapy with the newer therapies that are very effective for people with FH, but they're very expensive. And depending on where you are, you will not have access to that. And the question is, okay, will all patients, will all people with FH deserve to be treated with a PCSK9 inhibitor? Certainly, when we're talking about homozygous FH, we're talking about a very, very bad situation. This is data from Ibero-American countries. We had data from Brazil, from Spain, from Portugal, from Argentina, Colombia, Chile. And as you can see here, this is one of the largest cohorts of patients with homozygous FH, and actually biggest one with children, 63 children with this disease. And you see here, 52% of the children, mean age 8.8 years, had already some kind of vascular manifestation or CHD or subclinical atrial or aortic or supraortic valve disease. And almost 70% of the adults age 39 had manifestations of vascular disease, clearly showing that homozygous FH, no question, this is very bad, needs to be treated from diagnosis and needs to be treated very aggressively. Interesting, actually, when we're talking about FH, most of us, we talk about heterozygous FH, right? And actually, this disease is associated with early atherosclerosis. So it's very rare to find old people not treated with heterozygous FH. So this is data from the aspirin study. Do you remember it was a study that tested aspirin in old people? And actually, they went after the prevalence of FH causing mutations in the population. And as you may see here, FH was found in 1 in 1,010 people in this study, in comparison with 1 in 256 in the general population, clearly showing that actually a lot of people died before they became old. So, okay, FH really kills young people, and definitely we must make early diagnosis. And actually, when we take a look at old people, actually, we can really have a good picture or movie, depending on the natural history of the disease, because the people with FH are born with the genetic defect, so they have a high LDL since ever. So this is something quite interesting. This is data that we published a couple of years ago. So it's 462 people with severe hypercholesterolemia, median age 66. And you see here, we have separated people where we found the molecular defects, who really had FH, from people with hypercholesterolemia where the molecular defects were not found. So you can see here, LDLs are a little higher in those with FH, 243 in comparison with those without it, 228. And then you can see here the prevalence of atherosclerotic cardiovascular disease was much greater in those with FH, 41% versus 27%. And early cardiovascular disease, 22% versus 9%. And quite interesting, the disease was much worse for men than women, as we usually see, right? But one thing that calls the attention is that actually these patients started therapy very late, so 54 for those with FH versus 59 for those who had hypercholesterolemia, but where the molecular defects were not seen. So I think this is a group of survivors, actually, but it clearly shows that many people will not develop coronary heart disease, even if they're treated late in the natural history of FH. In no manner, I'm not advocating that we should not treat, but I like to emphasize this heterogeneity in risk. And actually, FH is not different from other situations. Actually, it's not only the cholesterol. Of course, cholesterol is very, very important. The higher the LDL, the greater the risk of disease. But other risk factors really make the difference for people with FH as they do for the usual population. So this is data from Spain, and actually the Safe Heart cohort, and this Safe Heart study, I guess, is the best the best natural history study that we have nowadays, because they all have molecular diagnosis, they're all being treated with state-of-the-art therapies. And actually now we have more than 10 years follow-up. Hopefully we will publish data soon. And I was able to collaborate with my colleagues from Spain. As you can see here, actually the risk increases as you get older, if you're a man, if you have hypertension, if you're obese, if you're a smoker, if you have high Lp(a). So actually we can really try to identify the risk on the, let's say, severity and presence of the classical risk factors for atherosclerosis. And it's important to emphasize that actually the equations that we usually use for the general population, like the pooled risk equation or Framingham scores or European score, are not meant for FH, because they do not consider the exposure since very early to high cholesterol levels. And nowadays, quite interesting, we have some equations. One is the Safeheart risk equation. There is one from Canada that's also very robust, that take in consideration this long-term exposure to risk factors. Interesting, FH, the risk of coronary heart disease in FH is not only modulated by the genes that cause FH, and as I said, of course, if you have a more severe genetic defect, you have higher LDL, you have a greater risk of events, but not only the FH causing genes apparently are operative on the risk of atherosclerosis in this population. So, okay, the more severe the genetic defect, higher will be the LDL, the greater will be the risk. But we also have other genes that are working against our arteries in FH. Actually, as you may know, now we have the polygenic risk scores that are being developed to identify people with a greater risk of having cardiovascular disease. And these genes usually have nothing to do with cholesterol. They have to do with other mechanisms like inflammation, thrombosis, insulin resistance, etc. And actually, we can have many different polygenic risk scores, and the higher the risk score, the greater the risk of events. And quite interesting, this is data also from the group of Amit Khera, and very elegant. And you can see here that actually people who have FH in blue, they have a greater risk of developing coronary heart disease up to the age of 75, people who have, let's say, a polygenic score for coronary heart disease. Okay, blue is higher than black. But as you can see here, even in people with FH, actually, if you have also the other genes, and if you have a higher polygenic risk score, actually, you have a greater risk of developing coronary heart disease. And you can see here, there was a big variability on the risk of developing coronary heart disease by the age of 75. In people with FH, they varied from 17% to 78%. And then you see here, actually, the higher the burden of other genes that you might have a greater risk, and the contrary is also true. So if you have less of these other genes, you have a lower polygenic risk score, you have a lower risk of events. So clearly showing that actually this heterogeneity on the risk of coronary heart disease depends on many factors. The usual, high LDL, the usual classic risk factors, and also depends also on other genes. So, and this has helped us to understand why sometimes we have people with 220 of LDL at the age of 65, and these individuals never had anything. We do a CTA, we don't see any plaques, and we have the same person with the age of 35, with the same LDL cholesterol levels, might have an MI and die or have lots and lots of plaques. And so definitely we have different aspects, and I think also we might have some protective genes that we don't understand very well, but there's a lot of people trying to identify these genes that might protect people who have risk factors for atherosclerosis. So I've been working many years now with subclinical atherosclerosis in people with FH. Definitely 90% of people who will die of an MI before we'll have a plaque, right? So clearly, and the greater the plaque burden, the greater the risk of events. This is very clear now, and the calcium score can be used to really help re-stratify the risk of cardiovascular disease, and usually is recommended for people with intermediate or borderline risk. But we have evidence actually that people who have risk factors, and if they don't have subclinical atherosclerosis, even with the presence of these risk factors, the risk is much lower than initially thought. So this is pretty clear. And also actually people who have high burden of atherosclerosis will have a greater risk. So this has been demonstrated for people with type 2 diabetes, for people with higher risk scores, clinical risk scores. So, and people with, let's say, moderate hypercholesterolemia. So, but what about people with FH? And actually we have data also from your hospital actually showing that people with hypercholesterolemia, severe hypercholesterolemia, who have low plaque burden, who have a lower risk of events, but not necessarily FH. So this is data that we published in 2020. This is a meta-analysis of the papers that had evaluated coronary calcium score in people with FH. So we had around 1,100 people. And actually, as you see, actually 45% of these individuals who had FH, most of them with proven molecular diagnosis. You see the mean age was 46. Remember that actually at FH makes coronary heart disease show up 10 to 15 years earlier than the usual population. So because one might argue, oh, they're young people. No, okay, they might be young people, but their vessels are not so young, so much older than the vessels from the usual population. 53% of them women, and you see the residual LDL was still high because most of them are in use of statins, but it still persists with 158 milligrams per deciliter of LDL cholesterol. But the most important information here is that 45% of these people did not have a coronary calcification. They had a calcium score of 0. And the question that comes is, what are the clinical implications of having FH, being treated, still having high LDLs, and not having coronary calcification? So one may argue, okay, maybe you might have a 0 CAC score, but you should have plaques, because a lot of people might have non-calcified plaques, especially if you're young, right? So because first we'll develop the plaques, then the plaques will be calcified. But as you can see here, indeed, 1 in 5 of our patients who had a calcium score of 0 actually had had coronary plaques, non-calcified plaques. But you'll see that actually less than 1% actually had obstructive coronary artery disease when a CAC score was 0 in this population of heterozygous FH. The question that comes is, okay, so is a CAC score of 0 really associated with low risk of coronary heart disease in people with FH, even considering that maybe 20% of them might have non-calcified plaques? And that's what we're trying to answer. It is not perfect yet, but that data are accruing. So the number of studies showing that people with FH with a 0 CAC score have a very good prognosis. Of course, if treated with statins, we're not talking about not treating them. And actually, the higher your calcium score, the greater will be the risk of having events. So basically, this is our data that we published in 2019. So we had 206 patients with FH, all with proven molecular diagnosis. So the mean age is 45. You see them, most of them are women, 36% only were men, 97% of them are taking statins. And actually, the average on treatment LDL was still 150, so still very high LDL. And actually, half of them had a calcium score greater than 0. And as you see here, those with a CAC score of 0 after a median follow-up of around 3.7 years had no events. And actually, the events occurred in only those who had subclinical atherosclerosis, so those who had a CAC score between 1 and 100, and then over than 100, you see here, the absolute risk varied from 2.6 to 4.4% per year. So, okay, this is interesting, let's say, proof of concept, but one may argue, okay, but this is still a small number of people, small number of events. So what else you can show? Then we have this paper from Antonio Gallo, from actually a group of patients from France and from Spain. And actually, we saw more or less the same thing that we had seen in our smaller paper. So here we have more than 1,000 people with FH, most of them with molecular diagnosis, ongoing lipid-lowering therapy with the statins and ezetimibe. And as you can see here, actually, those are the CAC score of 0. From 630 people, just 3 patients had a cardiovascular event. And actually, from these 3 patients, 1 had a stroke, 1 was not taking a statin, and so actually clearly showing that actually this is a very low risk of having events if you don't have a coronary calcification in your arteries. And as you may see here, those with a CAC score of over than 100 actually had a 32-fold greater risk of having events in comparison with a CAC score of 0. The argument here is that, okay, it's a bigger number of patients, but still not necessarily a huge number of events. And the follow-up is not so long, right? Just 2.7 years median follow-up. And then we have this data published this year from Japan, from the group of Dr. Ayato Tada, and these are 622 patients with FH, not all of them with molecular diagnosis. 70% more or less molecular diagnosis. But you see long follow-up, 13.2 years, and very well treated. On treatment LDL of just 108, much higher than the studies from Japan and from our studies in Brazil. And actually they had 132 events. But as you can see here, we have a longer follow-up, and actually you see that the results are exactly the same as we saw with our smaller cohort and then with the bigger cohort from Spain and France. And actually people with a CAC score of 0 had a very, very low risk of having events during the follow-up, just 1.2 per 1,000 patients. Those are the CAC score between 117 and greater than 107, 78.8. So clearly showing here that if your CAC score is 0 and this occurs in more or less 50% of the population, actually, if you're treated with statins, probably your risk is not high. So, and of course, the contrary is also true. So the higher the burden of subclinical atero, the greater will be your risk. And this is interesting because actually we're just relying on calcium. We're not relying on the CTA findings, but actually give us, let's say, lots of we can really trust, I think, in the calcium score, even if, let's say, 20% of these people will have non-calcified plaques. Okay, and actually, when we take a look at the literature and we evaluate the studies that actually tested calcium score in people with severe hypercholesterolemia having FH or not, okay, apparently FH is higher risk than non-FH, people with severe hypercholesterolemia, we saw exactly the same. So you have your study, you have studies from Denmark, we have data from MESA study, clearly showing that actually if your CAC score is 0, and you're treated, of course, with statins, the risk of events in 10 years varies from 0 to 11%, clearly showing that the risk is much lower than expected for people with severe hypercholesterolemia. So definitely this is something different. And in my opinion, this might help us to guide the more expensive therapies for our patients. So basically what we should do, I think we must do risk stratification, especially when we don't have all the available resources for treating everybody with a PCSK9 inhibitor. And maybe you could do that using a risk equation and add the CAC score, or you can just do the CTA on the CAC score and use that to really separate who's going to have a greater risk or not. Interesting, we did this, this is, let's say, another paper from our cohort that actually we calculated the vascular age in comparison with the biological age, and actually added the vascular age to the Framingham risk score that is not appropriate for people with FH. And as you can see here, we have improved a lot the risk discrimination. So almost 0.9 of area under the curve when we use the vascular age that was derived from the calcium score. So really, I think correcting for the exposure to high cholesterol since very early. So I think we have ways. So we can, see the risk factor, we can use the risk equation, but we can, I think, let's say, fine tune that, adding the calcium score to the risk equation and get, let's say, a better way of identifying higher from lower risk people with FH. And in 2016, actually, we had this idea, but we didn't have all the data. But we try to come, let's say, with a definition of severe familial hypercholesterolemia, and actually those with the more severe disease should be treated more aggressively. So if you have homozygous FH, if you already have coronary heart disease manifestation, if you have many risk factors associated with high cholesterol, or if you have, let's say, subclinical atero, definitely you're higher risk, and definitely you must be treated more aggressively and use the newer therapies. And I believe this is something that might help us to increase cost effectiveness. We were very happy because actually they tested our definition, at least with the clinical things. They didn't have the imaging data on the Simon Broom cohort. That is one of the most famous ones in the world. And actually, our definition was associated with the greater risk of events. So definitely this is something that we must consider. So what about the therapies very quickly? As I showed you, statins can make a lot of difference for people with FH, but unfortunately, as you can see here, actually almost 40% of patients with FH that were enrolled in the FHSC registry were not being treated adequately. And actually, the majority of our patients actually were still with elevated LDL cholesterol levels, and actually less than 14% actually had LDLs less than 100 milligrams per deciliter, and less than, let's say, 3% less than 70 milligrams per deciliter. But the question that comes out, should all these be really treated so intensively? Can we do risk stratification in order to really have a more cost-effective therapy? This is how I see it. Of course, as I said, PCSK9 inhibitors can do a lot for our patients. This is data that we published some years ago, really showing that we can add a 55% extra reduction in LDL cholesterol for people with severe heterozygous FH, and around 20% reduction in those with whole FH. And as you see here, the rates of cardiovascular events in this very high risk population, because most of them already had coronary heart disease, were much lower than the expected ones, because certainly PCSK9 inhibitors were doing the difference for the patients. And actually we have other therapies. Now we have inclisiran, much more easier to administer than the monoclonal PCSK9 inhibitor. So we can give 3 injections per year. We reduce LDL by around 50%, right? And we're actually, in the near future, we will have the oral PCSK9 inhibitors, and definitely people with FH, especially heterozygous FH, will be a target for these therapies. Actually, Christy Ballantyne is coordinating a very big trial with this oral PCSK9 inhibitor in people with FH. And hopefully we'll have good news for this population. And we also might have the return, right, of the CETP inhibitors. This drug, obicetrapib, is very powerful in reducing LDL cholesterol. As you may see here, reductions in more than 60% in LDL when associated with the ezetimibe. So might be, let's say, a less expensive alternative for people with FH. Interesting, LDLs really go up. As you can see here, more than 130% increment in LDL cholesterol. That's crazy. But we believe that actually this new drug will bring benefit because of the intensive LDL cholesterol lowering. And then there comes the issue of customized therapy. Okay, we might have these newer therapies, very effective. Hopefully they're safe also. Should everybody with FH should get them? That's something that definitely we must think about. And this is what we proposed in this editorial in Circulation, that actually, okay, if you have a CAC score greater than 0, and especially if it's greater than 100, definitely you're very high risk heterozygous FH, and you must be treated aggressively. But if your CAC score is 0, and now we have, let's say, stronger data showing that the risk is not that high, maybe statins alone and ezetimibe that are not expensive might be enough to treat these people. And even if LDLs, okay, still persists 140, 150, maybe not necessarily must go on and lower them more. One may say, oh, but let's say that you are really making these people have the similar risk of the usual population, but maybe you could go further and make them have a lower risk. Okay, it's fair, this argument, but definitely we must have more proof on this. So a few words on pediatric patients. Definitely we must diagnose early the disease, and statins can make the difference for those kids. This is data we published on PCSK9 inhibitors for kids with heterozygous FH with still with high LDL cholesterol levels. The average LDL here was around 180, and kids were taking statins, okay? And we were able to reduce LDL further around 38%. This is 2-year follow-up. And actually, you see here, those kids who got placebo in the randomized phase got evolocumab, and you see here that LDL went down by 35%, and apparently very safe. And we have some suggestion that actually, depending on the situation, let's say higher risk kids, maybe PCSK9 inhibitors can bring some kind of benefit to them. This is data not yet published, was presented last year at the ESC, that actually suggesting that evolocumab on top of statin, in comparison with the statin alone, could reduce the progression of the carotid intermediate thickness. So suggesting that we could reduce let's say, the pace of subclinical vascular disease development. Whether this will benefit kids who become adults in reduction of risk of events, that this is something that we don't know yet, but definitely higher risk patients must be more must be treated more aggressively. And finally, for the more severe ones, the OFH, we classically use the LDL apheresis, right? It was very effective, but very cumbersome. Every week, every 15 weeks, you have to go there and filter your blood, right? And now actually we have more experience with lomitapide. That's a drug that blocks MTP and reduces LDL by around 30 to 40% in homozygous FH patients. And apparently safe, we have hepatic safety with this drug, because the issue is that it could cause steatosis and maybe non-alcoholic fat liver disease, but happens this is not the case. And now we have this newer monoclonal antibody against ANGPTL3 that can reduce LDL up to 45% on top of all the stuff that we're already doing, lomitapide, PCSK9, LDL apheresis. So we get an extra 45% reduction in LDL. And nowadays, we really are able, if we give all the therapies, to normalize LDL cholesterol in people with homozygous FH, which is the most severe form of the disease. Certainly, these therapies cost a ton of money, and it's really complicated. But now at least we have therapies. In the past, we didn't have them. And we must find ways of really increasing access for these therapies for people with really these more severe forms of the disease. So to conclude, and we might have some time from Q&A, FH phenotype is frequent, right? And definitely we must identify people with FH. We must treat index cases. We must find the families, treat the families. We should start treating early, right? The disease is associated with a greater risk of cardiovascular disease, but as I showed you, this risk is heterogeneous, depends on many factors like LDL cholesterol, the other genes, the classic risk factors. And in my opinion, subclinical atherosclerosis, especially coronary subclinical atherosclerosis, can help us a lot in identifying the people who will deserve to be treated more intensively with the more expensive therapies. Everybody should get statin ezetimibe, in my opinion, but the more expensive therapies definitely should be set for people with a higher risk. And in my opinion, we are accruing the data. It's not perfect yet. We still have some limitations, but we are accruing the data in really to come with some robust tools to risk stratify our patients and definitely to really make it more cost effective. So again, I really like to thank the kind invitation. It's really a privilege to address you, and hope we have some time for Q&A. Thank you very much.
Thank you so much, Dr. Santos. Amazing lecture, and I think you kind of created this concept and you pushed it forward and added so much to the science that has inspired us to study the same topic. If you have any questions, please put it in the Q&A. I'll start with one. You talked about the use of calcium scoring for risk stratification, and we've studied the same thing. Do you think there are any other areas that we should be looking, any other imaging risk factors that we could use to stratify these patients in any other parts of the body?
That's an interesting question, Leandro. So because classically we used to use the carotid IMT, right, for people with FH, especially in Europe. And especially for kids, I think we still have a place for it. I think from the general population, it's pretty clear that actually the CT imaging, so CAC score and CTA, is much, let's say, more robust for identifying people at a higher risk of having MIs or dying from heart disease rather than the IMT or even plaques, right? But, you know, depending on the severity of FH, you really might get disseminated atherosclerosis, right? So in the more severe forms, you might get carotids, you might have in the aorta, you might have in the peripheral artery disease, femoral. So I think this might be useful, but in my opinion, I think the strongest data that we have, and definitely this is where we should focus, should be in coronaries. You know, in the US, is to have a CAC score is much cheap. It's not very difficult. For here in Brazil, it's quite weird because actually reimbursement exists only for CT angiography. Okay, might come with a calcium score, but you know it's a little bit more complicated. But we don't have evidence that actually, if you take a look of Confirm and other studies, registries that were done in the usual population, that actually CTA will bring much more information on top of the calcium score when we're talking about risk stratification. So, okay, if you have them, fine. But I think calcium score is very robust, and this is where we should focus. I don't know, maybe, you know, nowadays we're talking about, let's say, calcium density. We're talking about newer therapy, let's say, imaging modalities in the coronary, non-invasive. So, you know, plaque characteristics. I think we have a lot of room, you know, to study these and see how they will help us in risk stratifying this population. No?
Thank you very much. Yes, I agree. And we have one question here from Dr. Bradlow from here, Montefiore. He asks, CAC of 0 versus not 0. I guess how much does it affect your therapy? Or
yeah, that's a good one, you know, and because it's really over than 100, it's really trouble, right? So as we saw, but let's say you have a calcium score of 10, right? I think that we have now to consider let's say the percentiles for age and gender, because let's say a calcium score of 10 doesn't mean that you have very high risk if you're young, but might mean that you have lots of atherosclerosis for your age, right? So I think this is something that you should think about. And actually, I think PCSK9 inhibitors should be used for people with calcium score greater than 0. This is how I see it, you know. And especially if it's over than 100, definitely this is someone who deserves to have it. Whether should have also aspirin, we don't know. We have data from MESA suggesting that might be the case, but it was not FH, right? It was the usual population. So these are things that we must think about, you know.
Yeah, very, very good point. And also probably the percentiles from MESA probably don't apply to these patients. Probably we need new percentiles, right?
Yeah, I agree with you. Yeah, and because, you know, they developed this much earlier, right? And this is something that we must consider, because a lot of people criticize us saying, oh, look, you have a lot of women and these people are young. But as I said, you know, disease starts earlier in people with FH, especially men, right? And at least 10 years, 15 years earlier. So if you have someone with FH, let's say by the age of 40 and never been treated, probably the vascular age should be something like 60 or even more, you know, even for a woman. So you know, all my patients were 18 years or older. I do a CT angiography here. We have a lipid clinic with a cascade screening program. And definitely we go after to check the arteries, you know, to see really if there's anything wrong. And when we find subclinical atherosclerosis, we really see the patient with a lot more care than when we don't find, you know.
That was going to be my next question, doing it in younger patients, but you just answered it. So you after 18 you image.
Yeah, and actually, you know, one might say, oh, maybe the CTA better than CAC score, right? We do the CTA because this is what we have available here at the hospital, right? But as I showed you, know, actually, we're trying to publish this data that I showed you from Kuram and also Reed Mizar. And actually younger people, they have much less chance of having plaques if CAC score is 0. And of course, as you grow older, you have a greater chance of having non-calcified plaques also if your CAC score is 0. But the obstructive plaques are really encountered in people with severe calcification. This is what we saw, you know. So and hopefully in the future we might also have, let's say, metadata from the cardiovascular events on this population, so we can really have stronger data, because it's still, you know, small number of events, but this is what we have, right? And apparently this is not much different from what we see in the general population with a CAC score of 0. So, and of course, the higher the plaque burden, the greater will be the risk.
So that's very, very interesting. So we have a question from, hopefully I'm pronouncing it properly, Damla Ates Kulkok, says, thank you for this great presentation. Are there any other factors that may affect CAC score, oncology patients, for example, etc., that can jeopardize our judgment?
So you mean probably people who got radiotherapy or something like that? We don't have experience with that, Damla. So because classically we have, let's say, people with CKD, right? They might have coronary calcification in the absence of atherosclerosis because they might have, let's say, the media calcification instead of intima. So, but these people have high risk, right? So actually, when you see calcium in the coronaries, you see trouble. This is how I think things should be considered, you know.
Yes, yeah, I agree. We have a question from Daniel Lorenzati now. Great lecture, thanks. He says, there is new data reinforcing the concept that the calcium score over 300 equals the risk of a patient who already had ASCVD event, talking about the Matt Budov paper. In the FH population, do you use a certain threshold for guiding the intensification of therapy? That's a very good point. Should we use the same cutoff or a different one?
Yeah, that's interesting, Daniel. The thing is that, as I showed, you know, if it's really over than 100, this is where the biggest issue that we might have, right? So just let me come back a little bit to one of my slides here. Just want to see one thing.
Yeah.
Because actually, you see in the paper from Spain and from France, actually having a CAC score of between 1 and 100 was more or less the same as having a CAC score of 0. And actually, the Japanese paper, it was associated with a greater risk of events. So in my opinion, actually, if your CAC score is greater than 0, you should be more aggressively treating the patients, definitely. And the higher the CAC score, the higher the risk. And I think 300 is too much. More than 100, definitely it's a lot for these patients. Remember that because they're younger people, right? So they might not get so much CAC burden as if they were, let's say, 60 or 70 or 50 something, because we're talking about people with 45 years old. So 100 is a lot of calcium for them, you know?
Yeah, no, that's very good. And so from Mike Pateau, one of our fellows, he said, what are your thoughts on aspirin for primary prevention in FH patients? What are the clinical factors may help you make this decision? Maybe lipoprotein A, maybe CAC over 100? Yeah,
that's a good question. We have evidence that actually an Lp(a) over than 50 milligrams per deciliter or 125 nanomoles is associated with 50% greater relative risk of having cardiovascular events in people with FH. So this could be one possibility. But I think the plaque burden, I think, is the best indicator for therapy, you know. And I think if LDLs over than calcium scores over than 100, definitely I'll put the patient on a PCSK9 inhibitor and possibly aspirin. You know, the thing is that when LDL is very well controlled, aspirin doesn't make so much difference in primary prevention. But you may say, oh, but this is not very well controlled, right? We're talking about people with FH. So I think aspirin is something that we should think about, you know.
Thank you very much. I think we answered all the questions, and you know, after your lecture, I have so many more ideas of things that we should look at. So hopefully
definitely we should work together.
Yeah, for sure.
Yeah.
So thank you so much again, and thank you for waiting as well a little bit longer. And hopefully we stay in touch.
Okay, no, thank you very much. As I said, it's a privilege and a great pleasure. And if you guys are going to the ASPC in Arlington, Texas, I'll be there in July. Maybe we can chat a little bit.
Okay, take care.
Okay,
Have a good weekend.